Let's jump into the case. We have a 76-year-old male with a significant history, presenting with a buttock mass and lower abdominal pain. Now this starts to raise all kinds of alarm bells. The pelvis AP film brings our focus right to a soft tissue density over the distal sacrum. The more you look at it, the more you start to realize that something isn't right. There's clear bony destruction here, not a subtle finding. The lesion itself extends inferiorly, dipping below the level of the pubic rami. Already, this suggests something pretty aggressive and destructive, and your differential list starts taking shape. But we're not done. Axial, coronal, and sagittal enhanced CT pelvic images reveal the full extent of what we're dealing with. We're looking at a large, soft tissue mass, centered right at the lower sacrum and coccyx. This is no small lesion. It's extending both anteriorly and posteriorly, with clear evidence of extraosseous extension. It's invading the bony structure, causing destruction of the sacrum and coccyx. And it's not done yet. There's enhancement within this lesion and even small foci of calcification. In fact, it's so big that it's displacing the rectum anteriorly, even thickening the bladder wall. At this point, all the evidence points toward one diagnosis: chordoma. Now, chordomas are rare primary bone tumors, typically arising from notochordal remnants. Their preferred hangout spot? The sacrococcygeal junction, just like what we're seeing here. These tumors are locally aggressive and can infiltrate nearby structures, causing all the havoc we've observed in the imaging. The differential list here isn't too long, but we do need to consider a few other big contenders like giant cell tumor, chondrosarcoma, or even a solitary metastatic deposit. But here's the clincher. On CT, the chordoma tends to originate at the sacrococcygeal junction, which is exactly what we're seeing, along with calcifications and internal septations, giving us even more confidence in the diagnosis. Management-wise, this patient is in for a tough journey. First things first, they need an MRI to extend the imaging field, evaluating the clivus, skull base, and also a chest CT for distant staging. But no doubt, this case is going to end up in the hands of the bone and soft tissue tumor team for surgical excision. Given the aggressive nature of chordomas, complete surgical resection with clear margins is the goal. An MRI will be key to guide the planning here. Now, chordomas are a unique bunch. They are histologically low grade, but don't let that fool you. They're locally aggressive, and though they rarely metastasize, they have a nasty habit of recurring. They can present with pain, neurological symptoms, or, as in our case, signs of compression and displacement of nearby structures like the rectum, leading to constipation. When it comes to imaging, CT and MRI really shine. On CT, these tumors appear as large destructive lesions with a soft tissue component, often showing intratumoral calcifications, just like the one we've observed. MRI, of course, gives us more detailed soft tissue contrast, with the lesion often appearing as a well-defined encapsulated mass that's low or intermediate on T1 weighted and high on T2 weighted imaging. If we see hemorrhage, we might notice areas of signal variability. The patient will need full local and distant staging, and once surgery is planned, the goal is to remove the tumor with clear margins to reduce recurrence risk. Post-surgery, photon beam radiation might be considered if the tumor resection isn't clean. This case really underscores the importance of imaging in identifying and guiding treatment for such aggressive lesions. And of course, don't forget to like, share, and leave your thoughts in the comments below. Your feedback is always welcome, and let's keep learning together.